Good evening, everyone. Today we are going to discuss management of sickle cell disorder in this series of Masterclass of Hematology. Uh, we all know that sickle cell anemia and related disorders are important diseases which we commonly encounter in our hematology practice. Although they are more concerned with the central part of India, but the patients of sickle cell or sickle beta thalassemia are seen all across the India, and with the increased migration, all of us are likely to see one or more patients, depending on the practice of this disorder. We have my teacher, my mentor, our faculty professor, Dr. Tulika Seth, to discuss on this important disorder. She will be discussing about the management aspects, including the newer treatment options which are available. I hand over the proceeding to Tulika ma'am.
Thank you so much, Dr. Mukul. It's such a pleasure to be sharing this platform with you. So, at the outset, I would like to thank ISHBT for this opportunity to talk about sickle cell disease. And this is a very important topic which the government has now also recognized. And all of us at AIMS are very happy to be working with the Ministry of Tribal Affairs, the NHM, Ministry of Health and Family Welfare, and ICMR in framing some guidelines for the country on diagnosis and treatment. The last time's masterclass was on the diagnosis of sickle cell, and today I will be talking mostly about the management of sickle cell. Now, sickle cell disease, as Dr. Mukul has rightly said, primarily affects the central part of our country, but there are many states, almost 17 states, where sickle cell disease is a major problem. The carrier frequency of the sickle cell gene varies from 1% to about 35%. So in India, looking at our population, we actually have a very large population affected by sickle cell disease. It is a major cause of morbidity and mortality, and it imposes a very heavy burden on the patient and their families. There are variations in the phenotype of sickle cell, not only in different parts of the world, but also within different regions of India. There are certain areas where patients have more leg ulcers, and other places it's uncommon. And even within the family, there can be phenotypic variations. So just like in India, we see so many different types of India, sickle cell is also of many types. Now, it is a variant hemoglobin, and we end up with hemoglobin S, which is different from the normal hemoglobin. And basically, this is just due to one single point mutation in which there's a substitution of thymidine for adenine at the position 6 of the glutamic acid DNA codon. And just this one simple mutation results in polymerization of the hemoglobin molecule, especially under times of stress. It decreases the deformability of the red blood cells, making it more rigid, so it's more likely to undergo hemolysis. And during times of stress, the red blood cell changes from its normal shape to this sickled type of red blood cell. Now, the sickle cell disease basically includes all manifestations of abnormal hemoglobin S levels, usually when there's a proportion of hemoglobin S more than 50%. And this includes the homozygous sickle cell disease, in which you have sickle hemoglobin in both of the alleles. And there are also many compound heterozygote states like sickle beta, sickle D, and other combinations. Sickle cell disease is a term which is more popular nowadays rather than sickle cell anemia, because there are patients who may have homozygous sickle cell but are not anemic and do not need transfusions. Often patients with sickle beta thalassemia have more anemia and will require regular transfusions, though we know that even the homozygous may also have anemia and require regular transfusions, but anemia is not characteristically always present. So when the hemoglobin S is present, it leads to, of course, the red cell changes. So these rheological changes that are there, There is hemolysis, and the hemolysis leads to many end products of the oxidative reaction, and this leads to endothelial activation and immune responses. So not only is there vasoconstriction, coagulation activation, endothelial dysfunction, thrombosis, but there is a state of inflammation. So sickle cell disease, unlike some of the other hemoglobinopathies where primarily the problem is anemia, here there may be definitely anemia, but there is vaso-occlusive crisis, there is activation of the immune system and endothelial dysfunction, which leads to thrombosis and a pro-inflammatory state, which leads to some of the late complications that we see. And these complications, as we know, are very serious and often life-limiting. So, as I said, the homozygous sickle cell disease is not just a red blood cell problem, but it is a pro-inflammatory state. And the sickling of the red blood cells and the cascade that it starts leads to the vaso-occlusive crisis, which we'll talk about in detail. And there is chronic hemolytic anemia. And this chronic hemolytic anemia leads to the free hemoglobin platelet activation and cytokine stimulation and the overall pro-inflammatory state. And now, not to frighten you, but this is just a diagram which kind of talks about all of the issues, and that is why simply treating the anemia is not enough. So we can see that there are many steps that are happening here. So we have the sickling, the vaso-occlusion, the endothelial dysfunction, and the sterile inflammation. And there are many important pathways that are involved in this. And that is why a good treatment of sickle cell has to kind of take into account all of these things. And so far we had basically been doing symptomatic treatment, but now we are moving into the area of more targeted therapy, and I'll talk about that in the new drugs later on. So the manifestations of sickle cell do vary a little, but but even in milder patients, there are protein manifestations, and it is said that the manifestations can vary between patient to patient and also in the same patient over time, depending on what is happening. And there's a very extensive publication by Balas, which is a 2010 paper, and I would definitely recommend the students read that once at least to understand the wide spectrum of problems that these patients have. And that is why it is important for sickle cell patients to be attached to a clinic where they can undergo regular monitoring and regular treatment to help them avoid some of the late complications and to manage their disease well. So in the CNS, patients can have stroke and they can have cognitive impairment, and these are due to silent infarcts, and stroke can happen at any time, even in the pediatric age group, and obviously more commonly in the adults. So CNS symptoms can happen. Urinogenital system is also affected. So priapism has been reported. Chronic kidney disease is very important. So these patients need to have good monitoring to prevent all of these complications. The hepatic system can lead to hepatic sequestration, hepatic crisis. So these are some of the systems that sometimes are forgotten when we think of this only as a anemia. And very importantly, the cardiopulmonary system is important because patients can develop pulmonary artery hypertension. The acute chest syndrome we are very commonly aware of, but patients can also have restrictive lung disease, and these complications are often life-limiting. So just a little bit of talk on the cardiopulmonary. We know that there's endothelial dysfunction in sickle cell disease. Both the anemia itself and the intravascular hemolysis both lead to pulmonary vascular disease and diastolic heart dysfunction. And both of these lead to the increased morbidity, reduced exercise capacity, and death. And restrictive cardiac physiology is very important for diastolic dysfunction and heart failure and sudden death in these patients. And if these patients have iron overload obviously this will compound the problem. And this is something that has been underreported and not evaluated to a large degree. Now, as I had said, there's a lot of variation in the phenotype. And why does this happen? So one is that we know that in India we have the Asian haplotype for sickle cell, but even within that we see many variations in different parts of the country, and as I said, even within the same family. And we have some idea that there are many other genetic polymorphisms of cytokines and other genes that are important, and patients who have certain polymorphisms may be more likely to develop one complication versus another. So for example, PMPR1B is more commonly related with renal failure, whereas inheritance of UGT1A is more commonly associated with cholelithiasis. So at the moment, most of these are only for research, but I hope in the near future we will be able to use these to help predict the phenotype of patients and predict and manage complications before they occur. So diagnosis, you already had a wonderful lecture last week, so I won't go into it, but obviously you have to start out with the CBC, the peripheral smear, sickling tests can be done. Solubility test, you have to remember that it's not useful in the newborn age group. And the diagnostic tests, we have all of these available at the higher centers, but sometimes at the smaller centers, we have to depend on solubility test and point of care tests. But it's important to remember, if you are suspecting a case of sickle cell disease, to take a sample for any of the diagnostic tests before you give a blood transfusion, because after you've had a blood transfusion, then the test is going to be interfered for another 3 months, or we have to depend on parental studies. So that's important that you should do the testing before, or at least take out a sample before you transfuse a patient. The principles of care are to improve the quality of life and the life expectancy of the affected individuals. And when we're talking about the general management, our goal is really to prevent and reduce the number of vasocclusive crisis in these patients and the complications. And of course, if patients develop any complications, we must treat the crisis and the complications adequately, promptly and effectively to prevent sequelae. At the moment, we earlier have been just focusing on analgesics, fluids, and antibiotics for treating the crisis. But again, we're moving towards more targeted therapy. So the evidence-based strategies that are there, I'm just going to list them here, and then we'll talk about how we are incorporating them in our care. So penicillin prophylaxis, we know, prevents pneumococcal sepsis in children with sickle cell up to the age of 5 years. And this is an intervention which is strongly recommended. And that is one of the reasons why we are looking at point of care tests or other tests to identify newborns with sickle cell disease so that they can go on to prophylactic penicillin within 3 months of age. And that intervention has been shown to reduce infant mortality of babies with sickle cell disease. Pneumococcal vaccine is also important. Hydroxyurea is very important, and there are studies both in adults as well as in kids. There's the baby hug study, which has been shown that even in children, hydroxyurea can decrease the number of crises. An annual transcranial Doppler done between the age of 2 to 16 is very important because it can highlight patients who need to be put onto a transfusion program and will help to prevent stroke in these patients. Long-term transfusion in these children who have been identified by abnormal transcranial Doppler is a very important intervention in stroke prevention. And by keeping the hemoglobin S levels below 30% in these homozygous sickle cell patients, again, we are able to reduce the stroke incidence. In patients who have anemia with the sickle cell disease, transfusions should be given to increase the hemoglobin up to 10 grams per deciliter. Increasing the hemoglobin beyond that is actually not good because it will increase the risk of stroke. So if they're anemic, yes, you can increase the hemoglobin by simple transfusions to 10 grams per deciliter, but we want to avoid increasing beyond that. Rapid initiation of pain medicines like analgesics or even opioids is very important. The sooner you treat a pain crisis, the sooner it is going to resolve. And use of analgesics and physiotherapy can be used in the early stages of avascular necrosis of the joints, so that we can prevent the joint destruction. And folic acid, 5 milligrams daily, is an intervention which we all use in all hemolytic anemias, and it is important even in sickle cell disease. So as I said, there are now many different types of things that we are going to be using to target the pathophysiology. One of the most important interventions is bone marrow transplant, and I'm going to talk about that in the end. And then there are some other targeted therapies which are available in India also, and I'll talk to them about them in sequence. So, are there drugs that are capable of modulating the rheological properties of the red blood cell? And how can we prevent vasocclusive crisis? And do we have drugs to prevent endothelial dysfunction? So some of these things are already, we are aware. And one of the very important drugs we are using is hydroxyurea. And hydroxyurea, if you see, actually is effective in almost all of the problems that is there, except for the sterile inflammation. But even in the sterile inflammation, by using hydroxyurea, you are decreasing the amount of white blood cells, and it does have some effect on that. Most of the other drugs like L-glutamine and others like Chrysaluzumab again are useful, but at the moment we don't have anything that is effective in all of the different areas. Hydroxyurea seems to be one of the very important ones that we have at this time. So there are 6 types of crisis that we see in sickle cell. The most important is vasocclusive crisis. Then we can see splenic sequestration, which usually happens in the pediatric age group. We can have infarcts, aplastic crisis, hemolytic crisis, and bone pain crisis. And all these can lead to the other complications like acute chest syndrome, increased risk of infection, stroke, AVN, kidney disease, etc. So what exactly is this vasocclusive crisis? So when the sickle cells they block the blood vessels, especially the smaller blood vessels, and this blockage leads to vascular obliteration and infarct. And with this infarct, we then get inflammation due to netosis, endothelial activation, and the nitric oxide and other things that are released by the chronic hemolysis. And this upgrades the adhesion molecules and ends up in different kinds of thrombosis and infarcts. So the vasocclusive crisis that is experienced by the patient is actually a painful episode. It results from the tissue ischemia, which is caused by vasoocclusion, which can happen either in the bone marrow, blood vessels, etc. And it sets off this whole cascade, which leads to the problems. The phases of a vaso-occlusive crisis are the prodromal phase, the initial phase, the established phase, and the resolving phase. And a vaso-occlusive crisis can actually last for up to 10 to 11 days. Now, this is important to remember because often a patient may present to the hospital. You may think that the patient has a vaso-occlusive crisis and you give some fluids and pain medicine and the patient is sent off home, not realizing that they may only be in the initial phase, there may be some waxing and waning before the peak of the pain and fever and the high white count and anxiety. And if you stop the treatment early, the patient may have a relapse and go on to have a even more prolonged course. So even if you treat the course early, you may have a course of at least 10 days. And it's important to make sure that the patient is being checked up and is on some treatment during this whole period of time. So the sickle cell crisis can often be precipitated by exposure to cold, drenching in the rain. In India, it's very common in the monsoon season, physical exertion, dehydration, any kind of injury, including surgery, psychosocial stresses. It may be idiosyncratic. There are some patients who may know when they're going to have a crisis, and infection infestations are always important, and sometimes we don't know what the cause is. But for many of these, we are able to often predict that a crisis is likely to happen. So when a crisis happens, then it's important to, as I said, to treat it as quickly as possible. So now I'm going to talk about the two principles. One is the regular preventative care and health maintenance of patients, and then is the crisis and complications. So we already talked about how these are the evidence-based guidelines that are there. And so these are very important to put into the regular care of the patient. And one of the important things is hydroxyurea. So hydroxyurea can be used to prevent vaso-occlusive crisis. It is not useful in treating a crisis, but when we have a crisis, when we can prevent crisis and acute chest syndrome, it's very important. So hydroxyurea has multiple benefits. It can reduce the bone marrow cellularity. It can increase the hemoglobin F. It causes macrocytosis, reduces the sickle cells, and it reduces the white blood cells and reduces the adherence of the sickle cells and improves the endothelial function. So there are studies to show in both children and adults that it can reduce the frequency of vaso-occlusive crisis, reduce painful episodes, reduce acute chest syndrome, and often it can also improve the hemoglobin and lead to a reduction in red blood cell transfusions. And there are studies to show that in some patients, it can reduce mortality. Now, when we are using hydroxyurea, it's very important to monitor patients because we already know that these patients are at risk for infections. So it's important to check that the baseline CBC is normal. Usually we start at a dose of about 15 milligrams per kg for adults. In pediatric patients, we start at a slightly smaller dose. Some doctors prefer to use a 10 milligram per kg fixed dose for children. Others start at 10 to 15 milligrams per kg for children. But whenever you start on hydroxyurea or whenever you make any dosage change for hydroxyurea, it's very important to monitor the patient because we do not want the patient to become neutropenic or to have any other problems. If the patient has low platelets or neutropenia, you may have to temporarily stop the hydroxyurea and then repeat a CBC. When the CBC becomes normal, you can restart at a lower dose. So it's important to remember that if the patient has had neutropenia or thrombocytopenia of less than 80,000 for platelets or less than 1.5,000 for the ANC, a temporary stop is okay, but that does not mean that the patient cannot be restarted, and you can restart after a few weeks with the dosage modification. And if the patient continues to have a vaso-occlusive crisis in spite of the initial starting dose, you can escalate the dose at 5 milligrams per kg every 2 to 3 weeks until you reach the maximum tolerated dose or until you reach a dose of 35 milligrams per kg per day. So these are the guidelines from BCHS, and these are the guidelines that we follow. And as I said, it's important to monitor these patients whenever you start or whenever you're making a dosage change. Now, so that hydroxyurea is used to prevent, but if you have a vaso-occlusive crisis, what do you do? So first of all, you have to recognize that it's a vaso-occlusive crisis, and you have to assess the patient. Many times the patient will need to be hospitalized, but sometimes the patient can be managed in an OPD setting or at home. Make sure good support is there for the patient, keep the patient well hydrated, and make sure that you counsel the patient and you set targets on how to deal with the patient. So as I said, the hydroxyurea is really important for a lot of these things, and that is one of our mainstay of drugs. I often see patients who are on hydroxyurea but only on it intermittently or on very low doses. And if we want to treat patients well, as I said, right now with us, this is one of the most important drugs, and it acts on many of the different areas of the sickle cell pathology. Most of even the new drugs that we have don't work so comprehensively. So again, going back to hydroxyurea, it's very important to make sure that you're monitoring the patient and you are looking at the different parameters. It's also important when you start that the patient has normal renal and liver function tests. If the patient has chronic kidney disease, then we start at a much lower dose, which is 5 to 10 micrograms per kg rather than the 15 micrograms per kg. At the moment, we only have hydroxyurea as a 500 milligram capsule, but we now have several companies that are going to be making 100 milligrams and other dosage of the dispersible tablets or even the suspensions. So that will make the pediatric dosing much easier. Now, adherence, as I said, is very important because many times patients we see are on hydroxyurea only intermittently. And if we don't have adherence, then we will not see the long-term effect. And often by looking at a CBC and seeing the low values of MCV and the hemoglobin F, if available, you can tell if the patient has been compliant or not. So a simple CBC and looking at the MCV will be important. Now, sometimes you can manage patients at home, and particularly we've seen patients in the rural areas and tribal areas often stay at home even if they have a vasocclusive crisis. But it's important to identify which patients can be managed at home and which patients cannot. So if possible, and the patient comes to the clinic, you must measure their vitals and their saturation. If the oxygen saturation is low, then this is a patient who should not be sent home. They will need oxygen support. An X-ray can guide you if there is a patch, then you may want to keep the patient in the hospital. If it's an infant, make sure that you check for the spleen size because splenic sequestration again requires emergency care and hospitalization, and assess the patient for their jaundice and if they've had any passage of cola-colored stool, examine for bone tenderness. So a good physical exam and history is important. Patients who will need admission to a hospital or even referral to a ICU would be the patients with a very high pain score at the triage, older patients, patients with high blood pressure because they may be at risk for a stroke. Also, these factors are more likely to predict for a longer stay in the hospital. So if you have a higher pain score, older age, a very high white count, or a homozygous sickle cell disease, then these patients may require higher hospitalization. This is a simple card that can be used to decide if a pediatric patient can be managed at home or may be managed in a daycare or in the clinic or needs admission to the hospital. So patients who have a lower pain score, no breathing problems, no fever, just simply some mild pain, these are patients who can be managed at home with rest and analgesia and some hydration. If the patient has fever, reduced intake, but has been immunized and has been on oral penicillin, could be managed in a clinic, but they should get pain medicines. But if the child is younger age, sick looking, high fever, or fever that's been going on for a couple of days, has a higher breathing rate, so depending on the age, if it's a child and the respiratory rate is more than 50, definitely these are children who need to be admitted. And if you have prior prism, splenic enlargement, children who've been admitted previously for sepsis, any altered neurological status, recently been discharged within the last 10 days from the hospital, or has a high pain score, these are children who definitely are worth admitting and will benefit from that. Pain management is extremely important, and we use the WHO pain ladder, which we also use for oncology patients. So initially you may give paracetamol, but other NSAIDs may also be given. Opioids like tramadol can be tried for mild to moderate pain. If there's severe pain, then morphine is recommended. Often it is not available, but if there is a cancer hospital, then sickle cell patients can be sent to the cancer pain clinics where they can get oral morphine. Sometimes if there's neuropathic pain or other pain, then the gabapentin, pregabalin can be used in these patients. So it's important to assess not only the severity of the pain, but also the type of the pain. Pain relief should be given as soon as possible. Patients in pain should be put into a quiet environment, and they can be given fluids, oral or IV. They should be checked for any infections or other comorbidities that may be needed, that may need attention, and blood transfusion may be indicated in some patients if their hemoglobin is lower than normal. If they have any kind of acute crisis, then that should be identified. And as I said, we follow the WHO pain ladder, but we avoid pethidine and meperidine in sickle cell patients. But apart from that, it is pretty much the same. So treat the pain while you're doing the other assessment, but avoid overhydration, as that can cause pulmonary edema. And patients can have both acute and chronic pain. So, and that's something that often we forget. And in children, sometimes it's difficult to assess pain. So it's important to use visual analog scales, and the visual analog scales can also be useful in adults. Sometimes when they're in a lot of pain, they may not want to talk to you so much, and they can point to the scale. The other points to remember for pain management is that you should keep assessing the patient. So it's not that you've given the pain medicine and you assume that it's going to work. If the patient is not comfortable, then you may have to repeat the pain medicine. You may need to give antiemetics. You want to watch for any signs of sedation or respiratory depression. Check the oxygen saturations. So it's important to monitor these patients as we are taking care of them. Now, some of the other complications we talked about are stroke. So acute stroke can happen, and it's important. This is a very critical thing, and so patients have to be monitored very closely. And the earlier you can identify the stroke, it's important, because the intervention will be more effective. So stabilize the patient, provide good oxygenation, careful hydration. Hydroxyurea can be used if the patient was not on hydroxyurea earlier, but of course that's not going to be the targeted therapy of the stroke. So you need to identify, do the neuroimaging, and do the treatment for the stroke, which would be similar to stroke management in adults. But later on, these patients would definitely benefit from a transfusion regimen. So when you have a stroke, you can, just as we do in adults, you can give TPA, and that if it started within 3 hours of the symptom, then you are likely to get a better result. But it's important to get a CT scan to make sure that there's no evidence of hemorrhage and that this is a thrombotic stroke before you do that. Post the ischemic stroke, patients can be put on a chronic transfusion program or on secondary prevention with anticoagulation. Acute chest syndrome is a very important entity. We see this in a lot of patients. They can have fever, respiratory symptoms, and a new pulmonary infiltrate that happens. And basically, this is a vaso-occlusive crisis that occurs inside the lung, and it can progress to ARDS. So the trigger may be an infection, or they can also be a concomitant infection, or it can only be a vaso-occlusive crisis without infection. But often whenever we think of acute chest syndrome, we do go ahead and give treatment for pneumonia as well. So the important thing is to make sure we admit these patients. They should be given oxygen. Incentive spirometry is important. An exchange blood transfusion can be done, and this in many cases will show an improvement in oxygenation if hypoxia is present. If an exchange transfusion is not possible, a simple transfusion may also be useful. And we, as I said, we always kind of treat it as an infection, so broad spectrum antibiotics are usually recommended, and bronchodilators may be indicated, and in some cases even anticoagulation can be done. It's important to watch out for pulmonary thromboembolism. Hydration, if done, should be only to prevent dehydration. So we need to have a balanced hydration and prevent lung edema. So these are the steps that we do for the management of acute chest syndrome, and time is again of the essence. And if all of these things are not available, then you may want to give oxygen, give some hydration, and transfer to a higher center if monitoring is not possible. And so this week was repeated. Okay, so now in pulmonary hypertension, how do we manage these patients? So these patients usually will be adults, and screening endocardiography is important because, as I said, the pulmonary hypertension and the concomitant diastolic defects that are seen lead to heart failure. And these patients, unfortunately, are not being identified too much, but regular echoes can identify which patients need treatment. And once we have identified them, they should be sent to a specialist who is able to manage these patients and help prevent the sudden death that sometimes can happen in these patients. Patients can have kidney problems, and kidney is one of the organs that is very commonly affected in such patients. And one of the most, so patients can have increased UTI, they can have obstructive uropathy, they can have hematuria. One of the very common things that is seen is hypostineuria, which basically is a low specific gravity and difficulty in controlling the osmolality of the urine. So, which is one of the reasons these patients need to have good fluids. But many of these complications, unfortunately, can also lead to end-stage renal disease in these patients. So good care and management of the kidney complications is important. So a urine test for albuminuria and hematuria should be done. Once patients have developed the problems, sometimes treatment with ACE inhibitors can be useful in preventing these patients with kidney problems from developing into CKD. If a nephrologist is available, then a regular monitoring should be done. If not, then the regular doctors should be following these patients, and it's important to have good monitoring to prevent the side effects of the drugs, as well as to prevent any further progression of complications. Infection prevention is very important, and as I said, penicillin prophylaxis is recommended for children less than 5 years. Beyond the age of 5 years, penicillin prophylaxis is not needed. In patients who are allergic to penicillin, erythromycin can be given. The conjugated vaccines are recommended initially for children and followed by the unconjugated vaccines. Influenza, meningococcal, and typhoid vaccines are the other vaccines that are recommended for patients. In adults who have not been immunized, they should also receive the conjugated vaccines. Health maintenance records are very important and unfortunately lacking. So all the historical details about how the child presented and what are the different problems and hospitalizations and blood transfusions, all of that should be there, as well as the investigations that should be done. And regular CBCs are very important. Reticulocyte count, hemoglobin, phenotypes, if available, are useful. Also, the regular LFT, RFT should be done in these patients. If patients are on transfusion, then a ferritin is important, as well as doing the urine analysis and regular chest x-rays, and these should be kept for future reference. In older patients, for higher investigations like a regular ophthalmology examination, echos, etc., should be done. These patients do need psychosocial counseling, and that again is very helpful in allaying anxiety and dealing with other problems. Now, blood transfusions can be life-saving in sickle cell disease, but it's important to understand that all patients may not need blood transfusions, and it's important to avoid any unnecessary blood transfusions because these patients can develop alloimmunizations. So we have both simple transfusions and exchange transfusions, and there are clear-cut indications for when we do a simple transfusion, like in acute anemia, or exchange transfusion, which would be there for multi-organ failure, acute chest syndrome, and other complications. If there is alloimmunization, it is a very difficult problem to manage, and these patients need to be sent to higher centers. So it's very important to do everything we can to prevent alloimmunization, and for that they need an extended phenotyping before we do that. If they do develop alloimmunization, you have to send them to a good blood bank where they have many units and they can give the antibody negative blood. And as I said, these are the indications for the different types of exchange transfusion. And exchange transfusion, if it is done, it is better to do the automated exchange transfusion, as there are less complications with that. There's a lot of non-drug therapy that is important. So very simple things can be done to help keep the patient, help them manage their temperature, hydration, and other things. And that advice is important. Nutrition is also very important for patients, and good nutrition advice can help patients prevent crisis. Now, the ultimate curative therapy is hematopoietic stem cell transplant, and that is the only thing that will really cure the disease and change the genotype. There are specific indications for patients, and the reason is that there is still a risk of mortality with this intervention, and so all patients with sickle cell disease are not candidates for hematopoietic stem cell transplant, but if they have had any of these complications, then they are recommended to go for a transplant. So as I said, now we'll talk about some of the newer agents, and that'll be the final part of my talk. So L-glutamine was approved in 2017. It's basically a nutritional supplement, but what it does is it reduces oxidative stress, and a study published in NAJM showed that patients who were older than 5 years and who were having more VOCs, when they used L-glutamine, they had fewer pain crises and reduced number of hospitalizations. So this is a nutritional powder. Unfortunately, even in the study which led to its approval, more than 1/3 of the patients could not complete the trial because it's a large amount of powder that has to be taken, and it can lead to nausea, chest pain, fatigue, and skeletal pain. But this is a supplement which has otherwise less side effects and can be used. One of the newer breakthroughs and one of the targeted therapies is Chrysaluzumab. It's a P-selectin inhibitor, and it was approved by the FDA in 2019 for reducing the vasocclusive crisis in patients with sickle cell disease based on the SUSTAIN studies. And in the SUSTAIN studies, basically, P-selectin is expressed on platelets and endothelial cells, and it's induced by inflammatory cytokines. And this is being shown to block all of these things and lead to reduced vasocclusive crisis. And this led to their approval. So it's an intravenous injection that can be given to patients and has been effective in patients who are on hydroxyurea and even those who are not on hydroxyurea. And it's helpful in reducing the VOCs as well as their hospitalization. And compared to placebo, the effect was quite significant. So almost half of the patients had a reduction in their VOCs, and as I said, it's an intravenous injection which initially is given every 2 weeks and then every month. Voxelotor is another agent which has been used in sickle cell disease, and it decreases the polymerization of sickle hemoglobin and reduces the hemolytic anemia, and this was approved in the HOPE study. And what it does is it actually, because it reduces hemolysis, it increases the hemoglobin. And in the what they found was that in this HOPE study, which had both pediatric and adult patients, the hemolysis was reduced in all of the patients, and the hemoglobin increase was also seen. So about 30 or almost 40% of patients had an increment in the hemoglobin. So this is an important thing which can reduce the need for transfusions as well as decreasing some of the VOCs. Though again, long-term data of what it does for stroke prevention and other things is not known. And when it's a tablet that's given daily, and it has been effective in increasing the hemoglobin, and it has a good safety and tolerability profile, but can lead to headaches, diarrhea, abdominal pain, fatigue, and nausea. Right now, there's a huge interest in sickle cell, and this is just a screenshot of some of the drugs that are coming up for sickle cell. A lot of agents are looking at anti-inflammation because this is something that is thought to be important for stroke contribution. And of course, many of these agents are not available to us, but things like simvastatin and omega fatty acids are being tried. A lot of antiplatelet drugs are being evaluated, but we don't have the data of that as yet. Anti-neutrophil agents might also be something that could be important, and so that's another potential pathway. So this, as I said, there's a lot of things that are going on. Increasing the fetal hemoglobin is important, and that has been done, one by drugs like hydroxyurea, but now in a better way by gene editing. So there's BCL11A gene editing that is going on. And so gene therapy, gene editing trials are there, and there are patients who are on this. There was some interruption in the gene therapy trials with 2 patients developing leukemia, but they felt that that was due to the conditioning that was given to the patients and not the gene therapy product itself. But again, as I said, this is at the moment on trials. In India, for patients who are on regular transfusions with sickle cell, they also develop iron overload. And at AIMS, we have developed a rapid cardiac MRI, which can be utilized on any MRI machine, and there's no kind of a company-sponsored software that is needed. So with the rapid MRI, rather than doing a 30 to 60 minutes, we can do an 8-minute rapid sequence and look at the cardiac and hepatic iron. And if anybody's interested, we would be very happy to share this with you. So to conclude, in summary, prevention and management of vaso-occlusive crisis with hydroxyurea is important. We need to do prevention and management of infection. So prevention can be done with prophylaxis and vaccinations, and management with early identification. For anemia, folic acid is important, and we need to monitor these patients. And if packed RBCs are to be given, they should be given carefully. And we should know the phenotypic blood grouping before we do that. Iron chelation and monitoring is required if patients are multi-transfused. These patients require monitoring for life, for health maintenance and complications. A subset of patients can benefit from the newer drugs, and bone marrow transplant is available in India for patients with high burden of disease, and more innovations are expected soon. So I'll end here. Thank you very much.
Thank you for a wonderful talk. And yeah, sickle cell is a huge topic, and it is difficult to cover in just 40 minutes. But you've covered most of the aspects in a very comprehensive manner, and highlighted from basics of the disease to disease pathophysiology and various treatment options available to us now and in the future. So, as I await questions in the chat box, maybe I can begin on the discussion myself. Ma'am, you have talked about anti-inflammatory drugs like simvastatin and others. Is there any role of conventional or the commonly used anti-inflammatory drugs available in the market, like NSAIDs, steroids, cyclosporin in this?
So there are a lot of studies that have been done. The effective studies seem to show that simvastatin and some of the omega-3 may have some role. But again, a lot of these studies have a lot of biases, and it's difficult when you're looking at these types of studies to really know whether the study design kind of gave you those results versus not. But it's interesting to note, when I kind of delved into this, nutrition seems to play a huge role, and taking a diet rich in fruits and vegetables is very important. And there's data even in the West to show that poverty increases the frequency and the severity of vaso-occlusive crisis. So I always kind of think that just popping a pill may not really be the thing, but it's sort of a whole lifestyle kind of a thing where taking care of the patients and maybe providing nutritional support and other things may help to alleviate their disease. One of the interesting things that I read was that stunting is very common in homozygous sickle cell patients, and the stunting is more in males than in females. So nutrition, and these patients, I've not gone into this, but if you go into the nutrition, sickle cell patients have a higher basal metabolic rate, which is one of the reasons that most of them are very lean and thin. So these patients need a higher amount of calories, and taking a diet rich in antioxidants is definitely beneficial to them. And since most of the time these patients have interrupted school because of the vaso-occlusive crisis, and because of the stunting, they can't do a physical labor kind of a job. This adds to their poverty and other problems. So even though we are health professionals, but I think we need to look at it from a broader social aspect and advocate for good nutrition and higher caloric intake in these patients.
No questions. So,
Dr. Mukul, Dr. Ravindra Kumar is there in the delegate. He wants to ask a question. Can I allow him?
direct question, or does he want to write in the chat box?
No. Actually, they have raised their hands and he want to ask the question directly. Can I ask him to allow?
Sure. Yeah. Why not?
Thank you, Praveen, for allowing me to asking a question. My question is that when we see that hydroxyurea is teratogenic and cannot be given to the pregnant woman. So before conceiving, that hydroxyurea should be stopped and another thing is when the sickle cell disease is common in tribal areas, and the pregnancy is usually not planned. So, what to advise to the reproductive age group women for taking hydroxyurea?
Okay, so both of them are very good questions, and usually what we do is that when for our patients, at least when they're planning to conceive, we can tell them that they should hold off the hydroxyurea, but at that time then often these patients may need regular blood transfusions, because if patients were on hydroxyurea they may have a drop. Often what we have done is in patients who come to us, if they have problems during pregnancy, we've had patients where they've had alloimmunization and other problems. So we often will stop the hydroxyurea during the first trimester, but if we need to then increase the hemoglobin and we're not able to do it, we have actually given hydroxyurea in the second and third trimester, and we've had normal babies. So again, I think you need to look at the situation. Even in the tribal areas, all you can do is just increase the community awareness and try to avoid taking it during the first trimester. But not taking hydroxyurea is also a problem, because if patients are not on treatment, then there is data from England and Africa and other countries that patients will have difficulty in conception, or they can have early miscarriages. So it's good to give hydroxyurea to these patients, improve their health, improve their hemoglobin, request them to, as soon as they get to know that they're pregnant, to maybe stop the hydroxyurea. And we have actually had some patients with thalassemia intermediate and all who actually continued to take it during the first trimester. So the warning is there, but we have not seen any teratogenic problems. But as a doctor, we would always advise to avoid taking it during the first trimester.
Hello, ma'am.
Good evening. Yes, please.
Good evening, ma'am. Thank you for a great presentation. It was excellent. Ma'am, my question is similar to previous question. As usual, hydroxyurea is one of the teratogenic agent. And when it comes to the cost of the therapy, hydroxyurea is very comparatively cheap, whereas Chrysaluzumab and other targeted therapies are very costly. So when you look at the upcoming therapies, is there any therapy that can come in between which can target just like hydroxyurea?
So at the moment, this is all that we have available. As I said, there's many things that are coming in the pipeline, and as more effective things come, things will get removed. What we are trying to do is to work with the government to see if they will cover the cost of the patients who are hydroxyurea resistant, or who are intolerant to hydroxyurea, because as you rightly said, Chrysaluzumab is very expensive at the moment. But the number of patients who are actually truly hydroxyurea failure patients are quite less. I see very few patients who are on the full dose of hydroxyurea. So I think before we jump onto the newer therapies, let's make sure we're using hydroxyurea to its full extent. I've actually found very few patients are there who are truly hydroxyurea resistant. And for those patients, then we can apply to government grants or other government assistance programs to get them onto these agents. And we're working with the government to see if they will ultimately cover this for the subset of patients who really need it. And the other option is transplant. I think we are underutilizing transplant in our country. Many of my students are in the private sector and they do hundreds of transplants for patients with sickle cell disease from other countries. But I feel that as we do better care for our sickle cell patients, there will be patients who are surviving who have the more severe phenotype, even in India. And those patients, I think, can be taken up for transplant. I do know of some people who are in Karnataka and Andhra who are doing transplants for Indian patients with sickle cell. So that again is a option that can be explored, and the government has a public-private partnership with Coal India for thalassemia patient transplants, and I'm sure we can convince them to cover sickle cell transplants for pediatric patients who have a severe phenotype so that they don't need to suffer and go on to develop more severe complications. But obviously, it has to be patients who have true hydroxyurea failure and who have some complications. Those should be the ones sent for transplant.
Yes, ma'am. Good evening, ma'am.
Good evening.
Yes, ma'am. It is very helpful to us who are practicing the hematology, especially in the developing institute like AIMS Jodhpur.
Oh, wonderful.
Yes,
You have again a very excellent program, and I think you're doing a wonderful job with the tribals in your state. So congratulations.
Yes, ma'am.
I hear
So
about
especially we have in Jodhpur just learned the sickle from our patient, because in the PJ I did very less sickle cell patients seen.
Mhm.
So we have one question, ma'am. One is Chrysaluzumab. We are receiving one patient through the army support because patient have multiple complaints with the avian and chest syndrome and anything. So endpoint for Chrysaluzumab, till when we need to give, ma'am?
So I don't think any of the studies have really said anything like an endpoint. It is an ongoing treatment, and you have to continue it. So that is again one of the reasons why I think in our country, if you have a young and fit patient, transplant to me seems a much more logical thing, because continuing treatment without any end, the finances eventually become very difficult. So if this patient that you have is young and otherwise a transplant candidate, I would think about that. If the patient is older and an adult who has a lot of end organ damage and is not a candidate for transplant, then he will need to continue on Chrysaluzumab
Yes.
Without any stop. Yeah.
Yes, both our kids, they are adolescent boy, ma'am. Yes.
So then I think, why not think of transplant? Yeah.
And the another question is the ma'am, because the long term if side effect of hydroxyurea other than pregnancy, because many times here we are giving, because definitely long term experience is yours much more than us, ma'am, in
So
the thel intermediate sickle both.
we have used my longer experiences with thalassemia intermedia,
Yes,
and
ma'am.
yes, we do know that it can reduce the sperm count in males, but surprisingly, it actually does not decrease the risk of decrease the chance of pregnancy. So in women, it is not really shown to decrease infertility, and it can definitely be given, and I think other countries also have recommended it.
And other side effect like hematologic malignancy or anything else on long term.
So again, long term, we've not really seen that, and
Okay.
there is plenty of data. And see, I think what happens is, because it is a drug that is used in cancer, people kind of think that this is going to cause cancer, but there are so many hematological conditions for which we use hydroxyurea, and that has not really shown to increase the risk of malignancy. So I think we should be comfortable in using it. And of course, once we get better targeted drugs that are designed for sickle cell and they are as effective, then I think I'll be happy to stop. But as I showed you, if you really look at the pathophysiology of sickle cell, the new agents, even Chrysaluzumab and all, for all their cost, they're actually only working in one facet of the pathophysiology, versus hydroxyurea works in so many different ways. So unfortunately, of course, it's a drug that is not designed for sickle, but it is effective, and we should use that until we get better drugs.
Good evening, ma'am. I just recently had a sickle beta thal pregnant. She
Okay.
was adequately controlled on Hydrea, but because since she conceived, we had to stop her on Hydrea. From her third trimester, she started having these recurrent episodes of Vasocclusive Crisis. So my question is it safe to use L-glutamine in such cases? And we've put her on chronic transfusion regimen because her hemoglobin is dropping till 4. She's also having some amount of hemolytic crisis. What is a safe target, ma'am, in third trimester?
So lovely hearing from you. And I think you're already doing a lot of the right things. But if she's in the third trimester, you could also restart the hydroxyurea. We have done that in a patient who had come to us in her second trimester with homozygous sickle cell disease, and she was alloimmunized when she came to us. And this was a very precious baby. And we kind of didn't know what to do for this mother. She had a hemoglobin of 4. She was alloimmunized, and her family had actually abandoned her at the hospital. And so we kind of took care of her, and we also used hydroxyurea. And that really helped to increase the hemoglobin and reduce the number of crises and the need for too many transfusions. We did transfuse her once or twice, but each time she actually hemolyzed, so we ended up managing the pregnancy a lot with hydroxyurea. So first trimester, definitely you want to avoid, but I think if you come this far and if you're having all of these complications, then you can start again with hydroxyurea. If L-glutamine is available, you can try that. But as I said, a lot of side effects are there with L-glutamine also. And the regular transfusions is very important. If she's not alloimmunized, and you don't want to use hydroxyurea, then you'll have to increase the transfusions to keep her hemoglobin at least, I would say, around 8 or so. So I think you're already doing most of the things, but I would say you can use hydroxyurea when you're, obviously talk to the family, explain to them, but after the first trimester, it can be used.
Thank you so much, ma'am.
So back to you, Dr. Mukul.
I'm just a small query from my side. So autosplenectomy is not very commonly seen in Indian patients. So do you consider penicillin prophylaxis or other vaccination for adolescent and adult patients who come to for?
So I think that's a really, really important question. There is a very nice paper by Dr. Sargent, which came out, I think, in 2016. And recently, again, people have raised that issue. Now, there's a few studies from India on infections. Now, there was one study that was done in which they looked at sepsis in 20 patients, and these were blood cultures, and they found that they did not have pneumococcal infection. But we know that patients who have pneumonia, they don't always have a blood culture positive, right? And we know that the pneumococcal organism is very fastidious. So even though in that paper by Dr. Sargent and another recent review, they've said that pneumococcal infections are not there in sickle cell patients. So I thought that was a very sweeping statement, and you need data for that. And in the same Dr. Sargent patient paper, which is an excellent paper, and they've raised questions, they've said the similar thing for things like AVN, that there's no data in spite of the fact that there's papers of 200 patients and other things like that. So I think it's important to ask questions. And I think, yes, we don't know as yet if all of the infections that we see in our Indian patients are related to pneumococcal infections. But there is evidence-based data to say that pneumococcal vaccination and penicillin prophylaxis is important. So I would follow those guidelines and give the evidence-based treatment until I have enough evidence to say that these interventions are not useful in our patients. So even if it will save a few children's lives, even if it will save a few adults' lives, I would say let's go ahead with that and collect the data. And if we can prove that pneumococcal infection is not a problem, fine. Obviously, if we have sickle beta thalassemia patients, they have a big spleen. Now, the autosplenectomy it's not always just because your spleen size is there or not there. It is the function. And you may have a small spleen that is present, but whether it is functional or not, it's hard to say. So I think let's err on the side of giving the prophylaxis because at the moment we don't have prophylaxis for all the other infections. And in India, we know that For geriatric patients and other patients, we are giving prophylaxis. So I think it's there, but I completely agree. I think your question is very important and it's a very good question. We need to collect more data. And but again, I mean, only blood cultures is not enough for pneumonia patients. If you can do bulbs in all these patients, if we can collect samples and we can show what is the organism leading to the acute chest syndrome or the pneumonia, then I think we can say, okay, now we don't need to do these interventions because they are not important for Indian patients.
And then last about maybe transplant. So sibling transplant, unrelated transplant, or transplant. Haplos are coming in a big way in sickle, but are they anywhere near recommendation at present?
So you are a transplanter yourself. And so I think at the moment, even for thalassemia, we are recommending matched sibling transplants because for our patients with hemoglobinopathies and of course with sickle cell and all, most of the patients who come to us are heavily pretreated. They have a lot of other complications. And I think for India, if we're starting to do more transplants for sickle cell patients, we definitely should focus on the matched sibling transplant at the moment, and especially if it is being provided by the government funds. And we need to make sure that we select the right candidate. So again, like we do for thalassemia major, we need to make sure patients don't have too much end organ damage. If they have, very bad livers, very bad kidneys, very bad hearts, they're not the right patients. But at the same time, they should have disease that is severe enough to warrant transplant because there is always a mortality risk. And I don't think any patient should be taken without good counseling so that they understand the risk and the benefit.
So thank you, ma'am, for a very comprehensive talk and answering all the questions in a very comprehensive manner again. So thank you, ma'am. Thank you.
Thank you. Thank you again for the opportunity and thank you for sharing the platform. It was a pleasure. Good evening, everyone, and stay safe.